All right, we're finally live. Sorry for the delay. We were supposed to start this at 11 o'clock, and we had some issues with the computer. A little glitch here. So my name is Tom Willman. We're doing a live presentation on low back pain and sciatica. I just a little hairy today. I just ran from my son's soccer practice, first grade practice. So I'm just coming from that and getting back into my therapist mode. But we have a lot of good information today on low back pain and sciatica. A little background to me, and a little bit of how we look at backs and how we can help you move a little better, a little less pain, even that pain you've had, that low back pain maybe you've had for years, or you just had this weekend. So in fact, when I was running around with kids, we were doing a contest. We were trying to grab their pennies. It was a little drill just to kind of get them moving with the balls and dribbling. And my back started bothering me. I said, it's kind of appropriate that I'm going to talk about it today. But anyway, so low back and pain and sciatica, I've been here for a few years in Paramus at Apex Orthopedic Rehab. We started the clinic in 2004. It's been a great few years, and we started wanting to do some things as far as workshops, just to give back, and so people had some real information about, what we do and how we look at patients and how we help people here. Because people really don't know sometimes about physical therapy. And oftentimes people don't realize that physical therapists actually treat a lot of spine patients. In fact, a lot of our patients, over 60%, are typically spine related. Low back pain, neck pain, upper back pain, lower back pain. Sciatica, numbness, tingling, weakness. Those are some of the things that we work on here. So, and it's a great approach. We've had lots of success, and it's been pretty exciting. So, hope you get something from this. Share this with anyone that might have these issues, if you know of anyone. Also, we have a back pain report. If you want, we could send it to you. We're glad to send it to the mail or an electronic copy. And post some comments. If you have some comments during the presentation, I'll probably have to address it at the end. But feel free to, and if we don't get to it, I'll try and do it on the comments. Once we post this to Facebook, I'll respond to it live there. All right, great. So our clinic is right here, right close to the right off Route 17 by the fireplace. Occasionally we get the wind changes direction, and we can smell the fireplace over here. So and we're right off the inside of the off ramp. So anyway, all right, let's move forward for our first slide. So ending low back pain and sciatica, we're going to talk about the McKenzie method and approach. And it's all about kind of knowing when you really have to take care of this problem and understanding when it's an issue, when it's not an issue, and our particular approach. So we want to know the facts and fiction. There's a lot of things that people think are what they should do for themselves when they have these problems. So a lot of misconceptions that are really good to get out there and really understand that it's not really accurate. But sometimes even physicians will talk about certain things like bed rest. That's not always appropriate for a lower back pain issue or someone that's got sciatica. So it's just good information. We're going to give you some of those during the presentation. We're going to actually go through a quick demonstration. Kathy's husband Don's going to be here, and we're going to show how we go through our evaluation. We're going to take you through some movements, and it's kind of simulating what it is. Don doesn't really have back pain, thank goodness. But we're going to show you how we look at how we actually go through our evaluation, physical, and also what we ask the patient prior to that. And also a few things on tips on prevention of back pain. If you can do a few simple things so you don't have to use a copay or dip into your health insurance, tips and prevention is a big thing we talk about, especially when people start feeling better. How can we not have them go backwards? And I have to say me. It's a lot of time to come to physical therapy, so I always try and think that a little prevention really can help you out a long way. So that's going to be our setup. Now, what are some of the risk factors? Like, what is a big risk, for people that, as far as developing lower back pain or sciatica or weakness, numbness, or some of the other things you'll get with sciatica? One of the greatest risk factors is actually, go figure, you've had back pain in the past. If you've had, unfortunately, it typically comes back, and it typically comes back worse. It's more severe, it's more disabling. It's one of the things that actually costs a lot of people, time away from work, lost time wages, utilization of a lot of healthcare dollars because of that. So we can prevent it again, time and money, it would be great. But that's one of the big risk factors. So if you've had it before, take a look. We have some other videos on prevention as far as how to use a lumbar roll, which we'll talk about later on, and other preventive tips. Smoking. People with back pain, people that smoke have a higher risk of back pain. In fact, if you have surgery coming up for your lower back, the doctors will often have you stop smoking 2 months prior to the surgery because they know it's just not going to take. It's not going to be as successful. So, but even if you don't have surgery, smoking is a risk factor. And I always say, like, there's a lot of reasons to quit smoking. This is just one of them. Lung cancer, other issues. But it also affects your lower back. They think the little circulation to the lower back is obstructed and impaired. So you don't have good healing. You're more prone to having problems in that area. So smoking is a big thing. There's a lot of reasons to not do it. Obesity, a little bit more weight on the skeleton. It's all physics. You know, you have to control more weight. It's going to put more pressure through your spine, and that can contribute to some problems. Originally, we didn't think so, but now we're seeing more and more. It's not the only factor. I mean, I have some very thin people that come in here, non-smokers, that have back problems. But if you have obesity and smoking, you're kind of hedging your bet that you might have some trouble. So just consider that. Just like with smoking, losing a little weight, it'll probably help your knees. It can help other parts of your body. And just be a healthier individual. Heavy physical work. These folks, like my brother's a carpenter. You know, it's very physical labor and all that, and it does put you in some positions that kind of make it a little harder on your back, and you are more predisposed with heavy physical work. They're actually sometimes very strong, but they still have some problems just by the nature of what they do repetitively. So that's kind of hard. Another risk factor is frequent bending, just kind of going forward over and over and over. My kids used to be over at the YMCA in Wyckoff, and I looked at all these healthcare workers, and they were watching my kids, and they're on the floor, they're leaning forward. I said, gosh, I feel bad for you guys. It's just there's a lot of that frequent bending. And often, too, bending and rotation, just as a note, is really hard. That's the worst combination. It's like a perfect storm. So frequent bending is a tough issue. Moms, healthcare workers. Nope, we got lost our thing here. We're just going to go back a little bit. Now just hit the button. There we go. We'll get back there. There we go. We're back to our slide here. So frequent bending is really a risk. So our mothers, just anything that has that. And I run into it here. I have to be careful. I'm always bending over people. I try and maintain my posture, but it's still kind of hard to modify everything. But I do what I can. So. And other things are static postures. Now, static posture means you're just in one spot too long. I'll have people that'll say, I didn't lift anything heavy, but I had a really long ride home from the shore over the summer, and we were like 3 hours, 4 hours in the car, and they get out, and all of a sudden when they get up, they have pain. And sometimes they never even had a history of problems. But that one position for a while kind of slowly, almost like you can envision this finger, even normal tissue, slowly over time, you slowly bend it in one position. Eventually, you start causing some harm to those tissues on the top. So that's something that's a big issue. Static driving, sitting. I'll tell a lot of my folks to get up every 30 minutes as a preventative tip, and also if they're having an episode, get up, move around, even if they don't have pain. Okay? So static postures are a thing. Poor work ergonomics, setting up your desk so you've got the monitor at a certain height. On OSHA, OSHA.gov, there's a whole thing in computer workstation setup. It's great, a lot of information. You even talk of things about, I never really thought of until I looked at the side, glare. Glare. The glare on the screen, like if you're close to a window there, you kind of crane forward, and that craning forward will cause almost like you're bending forward, even though you're sitting. So if you can play around with that, different things as far as how you work, your workstation, if you're a laborer, assembling things, if you can get something that's a little higher for you, a table that kind of adjusts. Those are all things that can make it a little bit friendlier to her. But if you have poor ones, it can kind of accumulate. Over time, it can cause some problems for you. Okay? Lack of physical activity. Your couch potato is kind of your static posture person. He's just sitting around watching, he's binge watching some show on Netflix, and after 4 or 5 hours, he's hobbling. He's just, he's lack of physical activity. So, if you're going to watch, you're going to binge watch, try and get up a little bit every once in a while and move around. And just, get into like a simple program. I'm not talking about an intense CrossFit or a boot camp, but just moving, walking, doing a simple program. So that's good. So just incorporate that into your day. I think the recommendation now is at least an hour a day of a physical exercise, and that's like a combination of strengthening, flexibility, and some cardiovascular. So, and the last one on this slide is twisting and excessive lifting. So twisting and a lot of repetitive lifting, especially in a poor position, can kind of lead to lower back problems over time. So next slide. So when do you see a doctor? When do you go, oh my goodness, I really should take care of this? When do I start getting nervous and say, I have to take care of this problem. I can't just deal with it? Because pain is, pain's not life-threatening necessarily all the time, but it does impact your life. but there's times when you really should seek help quickly. And I call them red flags. Okay, so when you have to see a doctor, not me, I'll send you, say, don't come to me, go to your doctor. If you're having progressive weakness, what does that mean? That means that you're all of a sudden, you go from just being a little bit of weakness in your legs to, I can't lift my foot up, and it's happening rapidly. This isn't just because you stop working out. This is something that comes on pretty fast. And you really want to get to see a physician quickly. If you're unsure, go to the ER or urgent care, but get an evaluation quickly. Because sometimes if you let this go too long, because you're scared of it maybe, or you don't know what, you don't want to go to the doctor, sometimes you don't get the strength back if you don't address it quickly. And I hate to see that. And sometimes it's preventable, sometimes it's not. So another thing is loss of bowel and bladder function. If you all of a sudden can't have a bowel movement, you have an inability to do that, or you can't control your urine, like you're having problems and you're having back problems at the same time. People do have problems as far as bowel and bladder, but what I mean is it's associated with your back pain or your sciatica. It's kind of paired together. That's when that's a big issue, and it can happen within a very short period of time. Within 24 hours, if you have that occur, a definitive change, you can lose that bowel and bladder function, and that's a tremendous loss. So consider that. It's not very frequent. It doesn't happen often, but it's something to consider. Sudden onset of balance problems. It's kind of related to the weakness we talked about. All of a sudden, you're very unsteady, and it's sudden. It can occur after a fall, but it can also occur without a trauma. So, all of a sudden, you're very unsteady on your feet. It's not that you're dizzy. You literally are just very weak, and that's something you have to really consider. A fever. You could have an infection, something going on in your spine. It's, like I said, it's not really common. If you've had a recent surgery, sometimes that's a risk factor. Sometimes you can have an infection related to knee surgery, especially more the joint replacements that are much more invasive procedures. You can have a fever associated with infection. So it's good to kind of check that out. And this is my favorite one. Every time I'll ask a patient, I say, do you have any unexplained weight loss? And it's called my I wish question. I wish I had weight loss. We're talking like you didn't go on a diet. You all of a sudden lost 10, 20 pounds. You may have a serious medical condition that's occurring, cancer or something else. So you really have to address that quickly. And, but it's very notable. It's not like you lost a pound or two, like you lost 5 or 10 pounds. A recent trauma we talked about, it could be a motor vehicle accident. And as you get older, sometimes it can be less of a trauma, especially someone that's got a history of osteoporosis or osteopenia. Their bones are a little more fragile. Sometimes it doesn't have to be a big blow or issue. It can be a smaller one. Severe and constant night pain. That's like something like a tumor, something that just doesn't change. It wakes you up. Like you wake up because of pain. You don't just wake up and have the pain. It's constant. It can be an infection, something that's very chemical and very serious. Satellite anesthesia, you can have numbness and such right around this area, the groin area. Pain below the knee, more serious. It's probably more lower lumbar spine related. Occasionally the hip can give you pain below the knee. And also history of cancer, which goes back into the unexplained weight loss, something more serious like that, especially when it doesn't change. So this is the sciatic nerve. It shows it's coming off the lower lumbar spine here, different aspects of it. This is the L5, L4. These are some of the nerve root branches that come down and actually go down into your leg. I have to get a better slide with this one. I'm sorry about that. It probably doesn't come up good on your Facebook page. And this is it's a bundle of nerves that essentially come together and form this thicker band and goes down to different parts of your legs. And they call it sciatica, is that something is affecting those nerve root branches that are making you feel tingling, numbness, sometimes even weakness, depending on where the irritation is occurring. So we'll get our skeleton. Hey, Don, can you get our skeleton over there? We're going to bring it over. And these nerve root branches come in here. They can come from a muscle tightening around something. It can come from the disc segments, can irritate the nerve. It can just be swelling or inflammation around there. And those are some of the things that can affect the sciatica. So when your doctor says you have sciatica, thanks, Don. When the doctor says you have sciatica, it's kind of say something's affecting that sciatic nerve root, but we don't know what it is. It's kind of saying you have knee pain. Well, what's causing the knee pain? So in the lower lumbar spine here, this is your back. This is a normal curve. This is some of the nerve root branches coming off. This is like your L4, your L5, your vertebral bodies, the bony portions here. This is showing the disc. This is the L4, L5 disc. This is the L5-S1, or the sacrum right here, this lower bone here. They call it S1. That's another disc right here. And this is depicting like a herniation that could create sciatica. So this is some of the anatomy here, and all these nerve roots go down into the lower leg and provide strength, like we talked about, sensation, and all these normal sensations. And when they get irritated, they can give you some of those pain, tingling, and something that's just not normal. So that's Buck. This is our skeleton, Bucky, that's his name. Anyway, so these are some of the areas. We'll talk about this maybe a little later on. But this is the lower lumbar, and this is where the sciatica nerve roots kind of exit the spine through there. All right. Okay, next slide. Okay, now this is depicting, if I went ahead and I cut Bucky, this is Bucky, right across like this, the disc. This is a cut through that disc. So this is the back of our spine. Those little tips you'll see on people right here. This is the spinal canal where your spinal cord goes through. And this is a cut through the disc. So the inner disc, you have the nucleus pulposus, and then you have the annulus fibrosus on the outside. When you have a herniation, the center of this disc, sometimes they'll refer to it as the jelly donut, gets displaced, and it starts pushing through these outer walls right here. And unfortunately, right where the disc herniations come out is where the nerve roots pass by. So sometimes it's the actual nucleus that's resting on the nerve, causing it to kind of not fire well, or maybe give you weakness. And sometimes it actually gets detached as well. So there's different versions of these herniations or bulging discs that can occur in the lower lumbar spine, and also the neck as well. But that's the inner portion shoots out, and sometimes the inner portion doesn't have a great nerve supply. So sometimes you're working on a back problem, you don't even know it. And then you have a little bit more nerve supply on the outside of the disc here. There's these annular rings here, and that's when you start feeling, I feel a little achy, or feel like I got something going on. And then eventually you can get more serious. One of the things that we keep in mind is there's a lot of people with these herniations that don't have lower back pain, but these are one of the things that sometimes can be a source of pain, okay? So realize when you get that MRI, sometimes it doesn't even match your symptoms. So there's a lot of people realize that have these herniations. It could be 50, 60%, especially over the age of 50, and then there's a lot of them don't have symptoms. So you don't get too nervous about this, but it's part of the picture that we try and go through here. We see a lot of people even without MRIs and have very successful treatment. But when you have the MRI, it kind of gives us another piece of the puzzle that might tell us a little bit more about what's going on. Okay. These are just showing what we showed Bucky earlier, so we don't have to go through this, but this is a side view, and one thing I like to think of it is this is a normal curvature here, just like Bucky here. It's almost like a spring mechanism here. As you look down from the top, it curves in, and this is a normal curve here. Okay, so it's like a spring mechanism. Okay, it's and that's normal. Some people think that's an abnormal spine, and that's what they're showing from a side view, and this is a forward view. Okay, let's go to the next slide. So some of the fiction, sciatica and back pain are genetic. Have to change the slide. There may be some genetic link actually now. I'll have to update that as far as if your dad had it or your mom had it. But, some of it is kind of like, did your mom and dad sit around and watch Netflix for 5 or 6 hours, 2 or 3 times over the weekend? Maybe they don't have as much physical activity. Maybe it's not so much genetic. It's not your parents. It's your parents' lack of activity or choices. So some of that can contribute to it as well. MRI and x-rays are needed prior to starting evaluating a patient for back pain. Not necessarily. If they have certain red flags, then we may want to get a basic x-ray. Fell down the stairs. I want to have an x-ray, make sure we don't have a fracture. Sometimes we need an MRI, but it's not essential to start an evaluation and to start feeling better. There's a lot of people that reflexively, unfortunately, physicians, and some of it is that they're just they have to cover themselves. A lot of people expect to have all these images because it tells us everything, but it's not always necessary. So, bed rest is often the key to feeling better. False. Limited bed rest is okay when it's really painful, but you don't want to just lay down for 1 or 2 weeks. In fact, what they found is a big researcher out of California found that if you go more than 3 days and don't start moving, you actually, your outcomes are poor. You actually don't do as well. And the general rule of thumb is to move as much as you can without really increasing your symptoms. Okay? So when you have to do that, but get up and move around a little bit as much as you can tolerate, as long as it doesn't set you back. Okay? We just talked about this. If I have a herniated disc on an MRI, is that often the cause of the pain? It could be. I've had MRIs, someone goes, wow, did you read my MRI? And they have pain all the way down the right side, and the herniation is actually on the left side. So sometimes it doesn't match what the patient's talking about, and what the patient's describing is very important. So you really want to educate your doctor, your therapist, on what you're feeling, how it occurred. That's a very important part of therapy or part of an evaluation for a physician to understand that. And it can be very confusing. Why is the bulge on the other side, the herniation on the left side, and I don't have any pain here, but I have all sorts of pain down the right side. So just that's something to keep in mind. A screening by a physician is necessary before starting a course of physical therapy. It's not actually absolutely essential unless we have those red flags. It's very safe to see a therapist first. Medicare has done studies on seeing a therapist first as compared to seeing a physician first, and there's no greater risk. We're really trained on how to make sure we don't do anything that's going to harm the patient. And we'll do a screen. And if the screen tells us we have to see the physician, we're not saying you don't see a physician, but we'll tell you when it's appropriate. That's part of our training. So. I just need to strengthen my core. I believe in core work and strengthening, but the core is not the be-all, end-all. You have to, if you're sitting down and slumping, you can have the strongest core in the world. Just that static positioning can eventually bother your back. So sometimes if we try and strengthen the core too early, we can actually flare up the person if we don't do it at the right time once the symptoms are managed, once we have a little better sense of it. So be careful about jumping into core, especially sit-ups are really no-no most times with lower back issues, can really put a lot of stress on the back. But we'll talk about that later. So my goal is to tell two cities. There's two different extremes we can have here. My goal is to see all my patients have success and avoid putting your head in the sand approach. I hope it just goes away. At a certain point, you don't want to have that ER visit. You have the weekend, you're going to have a family outing, or you're going to have your friends over for dinner, and all of a sudden that low back pain becomes something that's acute, severe, and you can't ignore it anymore. So I want you to kind of take a proactive approach when you can. Some of it's even doing things that I give in my back pain report to try and manage it while it's not acute to the point where you just can't function. And then all of a sudden it's not an elective thing. You have to run to a doctor. You have to run to the urgent care. And it really starts affecting your day. Let's do it on your time frame. So let's try and address that. So success, what I see as success for your back pain, sciatica, if you've come here or before, is that you know what to do and what to do the first when it happens. Like what can I do to maybe change this problem that I'm having? Understanding of what makes my back worse and better. A lot of these things are mechanical. I sat too long, I lifted an awkward way, I did a new exercise that for whatever reason bothered my back. And being in tune with that is really important. Things to do and avoid immediately when your back goes out. That's something I really want my patients to know, and that's success for me. Understanding that, so when the next episode starts, you can manage it without coming to me. I mean, listen, if you have to, you have to. That's why we're here. But I love when someone says, I tried that exercise that I did 2 years ago, and it seemed to help me, and I slowly started to improve. I love that. Knowing when to seek help is another one. That's where it gets back down to the red flags, when it's an issue, when it's not. And also just having a few simple exercises to manage your pain. Some simple things that you can do at home without any kind of crazy machinery or anything like that. Some very simple things that you can do at home that can change your problem. So, but we don't want is that, I don't want to hear that every episode gets a little worse. You're really not aware of the triggers. You haven't made those changes. I hate to have you stop exercising or doing that tennis game because you have pain and you don't know what to do with it. So you stop doing the tennis and you stop enjoying life and you kind of curtail your enjoyment. People say, wow, I started having trouble and I stopped doing left, then I started gaining weight. And we know that obesity and weight is not great for backs. So you start kind of getting into this backward slide. And eventually the back dictates everything. That becomes the first thought in your mind as far as what I'm going to do. The day starts with, I got a long drive to work, or I have to do this, and you're always thinking, it's ever present. And that does affect your quality of life. It affects your personality. And you'll see people here, when they first come in, they're just, you don't know if it's a personality, they're more withdrawn, and they start feeling better, they start kind of cheering up. And that can affect your family, your interaction with your spouse, your kids. So if you can take care of it, that's the success for me, is someone that knows how to manage that. Just like we said, you're kind of distracted at work, things take a little longer. All those things kind of multiply into less quality of life. So a few years ago when I graduated from physical therapy school, I was kind of doing like a bunch of different ways I call it an eclectic approach. I did a bunch of different things. I strengthened people, I stretched people, balance, I worked on posture, endurance, and I kind of had some success. I mean, I did all right. But at a certain point, I felt like whatever continuing ed course I took was like the flavor of the month, they call it. You know, everyone that came in after that continuing ed course, I did a special stretch. But it wasn't really a system. I didn't have a system that was very reliable that taught me, and I grew from it. So eventually, I finally adopted it, and I started taking the continuing courses in the McKenzie approach and developed my system more on how we look at the back. Because the other way, it was just so many variables. I really just never knew if it was the stretch or that or a combination of everything, or was it just time passed by. As time passed by, the patient got better, even if they weren't with me. So those are some of the things that I struggled with at the start. So, next slide. So finally, I committed to the system, and my results for spinal treatment and now later peripheral joint or shoulder or knee treatment really got better. It went good to great. And with the system, I was able to tell within 2 or 3 visits with the McKenzie method whether I could help that patient. And one, it solved the issue as far as where to take him. I also knew if I could help him and maybe send him on to a neurosurgeon or send him home with some exercise, but I can kind of tell pretty early on if I could help him out. And that was very rewarding for me, and there was certain consistency of that as well. Ultimately, with this system, we were looking for one exercise or one movement that could reduce or eliminate their back pain and sciatica. And that's what we're looking for. Based on movements and the evaluation, what can we do to have that patient take one thing home that they can do a lot of to reduce their symptoms? So after a thorough evaluation, we provide only one exercise to abolish your back pain or sciatica. We also work on people with neck problems, which is not what we're talking about right now, but good or bad, we have one variable. We give you one thing and it doesn't work. We know we got to move on or reevaluate you, or send you on to the doctor, or change our approach and reassess you. So that's the great thing. And compliance-wise, we have people that say, I get overwhelmed, I don't have a lot of things going on, I've got kids running here and there. I'm just asking you to do one movement a lot. And that really has been very powerful and very helpful. And it's very clear to the patient what's helping them and what's not. So finally committed to the system, and I feel like it's a lot more structure and to really help me out and help my patients out. So the founder of this was this guy, Robin McKenzie, and he was the founder of this type of assessment, how we look at people, help them move better, and treatment techniques. And the treatment is based on a series of movements, and they're called loading. You move in certain patterns over and over, and we see a pattern to it. We move forward, we flex forward, we lean back, and after we do it a repeated amount of times, you see a pattern. They may actually get worse, they may get better. And then you classify patients how they respond. Do they respond to moving forward, to going to the side, backwards? And then we develop a plan. So a lot of people, when they think about McKenzie, if you know anything about him into therapy before, they always think of the disc model. And there's all these ideas on how the disc moves. When you move, how does the disc, does the herniation go away? Does the bulge go away? And we're more concerned about really how you feel and how it changes your movements. If you start moving better, feel a little bit better, and how it changes how your pain moves. So, next slide. Oh, that's not a slide. Next slide. So in the evaluation, we're going to talk about a history. We're going to talk to the patient, and that's very, very important. We want to know, these are fancy words, but we want to know if they've got good reflexes, do they have any weakness that they're not aware of. We want to see how their range of motion is, how they move, and how they feel when they move. What makes it better or worse? And we'll also ask in the history, we'll say, how's sitting, how's standing, how's walking, how's bending over to touch your toes, put your shoes on. And that tells us a lot about what we'll probably get when we actually go through the formal physical assessment. We ask them also, we educate them on how the pain moves and what's good movement of the pain and what's a bad movement of the pain. Then I actually have a Facebook video on this if you want to see. It's called centralization versus peripheralization. Just fancy words for if the pain is moving to where we think the origin of the pain is, or if it's moving away. So We talk about red flags so our patient knows, hey, you know, I got this problem. All of a sudden something changed last time I saw you. I think I have to go to the doctor. Okay? And the nice thing about this progression is we take you through these movements in a gentle way, and it's pretty safe because we'll constantly getting feedback from how the person's feeling, how they're moving. So that's basically the the strategy. We talked about a lot of this. We talk about posture. Sometimes we'll stretch the patient. Sometimes we don't. Some instances the patient can get better all by their own movements. Sometimes they need us to do a specific stretch that kind of helps them along. Most times the stretch is probably 25% of recovery. 75% is what the patient takes home and does on their own, and also the prevention. We also go through, once we get everything controlled, we're feeling good. Patient's like, I'm feeling pretty good. We also talk about this at the early on, is how to lift properly, talk about the workstation, ergonomic station, using a lumbar roll, icing, and all these other things. We also give them some strengthening. We talk about the core. We'll give them some strengthening and things to help them get a little stronger and a little more stable. Once everything is controlled, and that one exercise, one movement has really helped them out. And also part of the conditioning and strengthening. So this is one of the slides. This is one of the exercises. This is one of the most common movements that we'll give. I call it standing extension. So you essentially take yourself all the way back like that till you feel the pressure and where you can't go any further, and then back into standing. I would say for people with lower back pain and sciatica, with the over 50 crowd, this one is probably the most prescribed one. The one that I find helps people the most is this one. Next one. This is the under 50 crowd, typically, not everyone. The under 50 crowd, they really like this exercise. So this is the same one, only in a kind of a non-weight bearing position, and it's a little more effective. You're basically doing a push-up, but letting your hips sag, and that's called a prone press-up. This is forward flexion or standing flexion. Some people benefit from that. Next one. This is the knees to chest. So forward flexion standing with weight bearing. This is non-weight bearing. This is the knees to chest. This is another form of flexing, only just flexing one side of your body. This is one they don't commonly see. Not a lot of people know about it. It's called lateral shift correction. You're essentially shifting your body like this, and you're kind of loading one part of your spine and opening up the other part of the spine. And this is one that some people really benefit from, but it's a smaller number. You don't see this one affecting people as much. This is me hugging my patient. Okay, sometimes they need a little help for that little shift. And the whole time I'm talking to them, I say, how are you feeling? Is this bothering you? Oh, the leg pain is getting worse. It's actually going into my toes. Okay, we got to adjust our position. So we are talking to them and kind of constantly monitoring how they're feeling as we're taking them through this. So it's a very safe system. It's a very gradual progression. It gives a lot of empowerment to the patient. A lot of onus is on the patient to kind of take control of this and really understand what makes it worse, what makes it better. I can't sit with them their whole day for things that are making it worse. Like, I really can't monitor them. They really have to know. So education is a big part of understanding how to help themselves. It can't just be what we do for an hour in here. It's just not going to work. If it is, it'll be short-lived. So once we get everything in control, we're feeling better. We'll essentially do recovery of function. That's just a fancy word for we start doing different things. We start challenging it. Is the back stable? Have we really figured this out? Or is this something that's not great? So if we find out a back movement and say, wow, after 5 or 7 days, I'm feeling great. I don't have any problems. We start challenging them. We have you do. You have to bend forward. You have to flex through life. You start moving and start incorporating more challenging things, returning your full range of motion. And then, at the end, if this comes back, we got to tell them, what can I do? And they got to know the rules. What can I do? What movement can I do? And most times when someone comes to me, the same movement that helped them a year ago, a lot of times that's the same movement that'll help them again. So I'll say, did you try your exercise? They'll call me up. Hey, I left you. I got a flare up. What should I do? And I say, well, dust off that old home exercise sheet and try and look at that book that I gave you and try that exercise. And you know the rules as far as the pain getting worse, getting better, and if you should see me. All right? We're going to go right past this. This is more technical stuff. We're going to move on. So self-management is the goal. That's what we want to see. These things are typically very chronic. The episodes can come back. Like we talked about earlier, there's a greater 50% chance of recurrence if you've had it before, a lower back episode, and typically it's worse. So let's kind of seize on to that and and really check it out and make sure we do as much prevention as we can. So a lot of things that I'll tell people is, what were the original signs that you felt? Like, what did you feel before it really got bad? And they'll say, I felt a little stiffness, but I got up in about an hour, I was feeling okay. That's your early sign. That's like your gauge, your barometer saying, you know what, if I take care of it now, I can prevent it from getting severe. And then you could be a little more careful in the morning. You could be more aware of your posture. You go back to your workstation. And is this all set up? Am I set up in the correct position so we don't have it really flare up? Okay. Big mantra you'll hear me repeatedly is don't sit more than 30 minutes. After 30 minutes, things just typically get bad. And unfortunately, you may actually not feel the pain during that 30 minutes, so there's no reminder. And pain's great. It reminds you when you have trouble. Sometimes when you're sitting, you don't know. It's really when you get out of sitting is when you go, oh, I didn't realize how long I sat. So if you proactively put on that smartphone, every 30 minutes, you get up or set it on your computer, it can really help you out. And you don't necessarily have to go for a long walk. I mean, I know we all have to work and we've got jobs, but get up, just move around, maybe try one or two of those stretches that I gave, the one stretch I gave, I should say. See if you can kind of loosen it up and get it back in line. Unfortunately, society-wise, we typically are in more of a flex. I call it a C society, or head forward, legs forward, and we want to get out of position. We just want to change that position. There's certain back problems that don't like to be arched, and actually things get worse. They prefer to sit, actually. But I would say more than the majority are folks or patients that don't like sitting, and that's all about prolonged position. So whatever you can do, even if you don't come in today, you don't have a question, you don't set up an eval, just start by not sitting for more than 30 minutes at a time, and that can really help you out. The other thing I'll tell people is, like my uncle from Texas, what can I do? I said, well, don't sit for 30 minutes. Try and get out at least 30 minutes of walking, as long as it doesn't flare up your pain. You can do it 3 to 5 times a week. It can really make a difference. And it's all part of that activity, keeping active. So, and it helps other things. Cardiovascular can help you out. Make those workstation changes. OSHA, like I said, .gov has a whole section on computer workstation. It shows you monitor height, keyboard, use of armrests, all these things that can really help you out. And quite frankly, you just feel better. You just feel more comfortable. You're more productive. You're not distracted by that pain, that low-level pain. Get an eye examination. This is kind of back, and we were talking about glare earlier as far as the computer workstation. I've told this story, and I'm going to bore everyone with it again, but eye pain, eyes, and you're losing your, as we get a little older, and that vision. And Kathy, that works with me right here, she always laughs at me. She goes, "You're not getting an eye evaluation. You're just simply moving your monitor height and monitor size and making it bigger and bigger." So I think she's partly right, but I think she's also onto something that can influence your back pain. That'll make you crane forward and crane forward. And not that we're talking about neck pain and headaches, but my wife, Sue, she had this horrible headaches for a while. I'll tell you this quick story. Horrible headaches, and she thought she had a brain tumor. She had all these problems, and she eventually went to a neurologist, and we checked into it, and it was, we were concerned there was something more serious, and I was concerned too. I was kind of hoping it was related to neck or something going on, but we decided, let's check this out. Went to the doctor, neurologist said, I don't know anything that's really going on here. Everything seems pretty normal. Your history, I don't know why you're having these. I know these are upsetting to you, but let's go ahead and, let's get rid of chocolate, red wine and coffee. And she kind of chuckled and says, you're trying to kill me? What was that? So, well, he goes, well, I don't know what to tell you. If you're not going to do that, I'm not going to prescribe a medication. Why don't you check your eyes and your vision? She goes, you wear glasses. She goes, I don't need glasses. He said, all right, well, then stop chocolate, red wine, and coffee. So she said, all right, I'll get my vision checked. So she got her vision checked, and she needed some glasses for work, for computer work. She used them for about 6 to 8 weeks, and after that point, she didn't have headaches anymore. So posture can be really powerful, what you can do, and she just needed some glasses to set her up so she wasn't coming forward. And I'm talking about a neck issue, but as you come forward, it kind of neck, the lower back, everything kind of gets affected. So that is something to kind of consider. It was an interesting story. I'm glad it wasn't something more serious, but it was scary up until that point. So I'm glad it was just a glass issue, just an eye issue. Understand your triggers and maintain your range. So understand what things flare it up, when things make it better. And once in a while I'll say, self-assess, how far are you leaning backward? Do you think you're losing it? Because sometimes you lose range of motion before you have symptoms and pain. And the last is an anti-inflammatory diet. A lot of leafy greens, dark greens are associated with anti-inflammatory qualities, which help other things. And dark leafy greens are a big thing as far as diets in general. We're probably, as a nation, we're probably eating less of that. And besides anti-inflammatory, it probably helps you with other areas as well. So, are you a candidate for this approach? You got to be active. You got to be willing to do one exercise. Not a lot, but even one seems to get away from some people. And it's unfortunate. It could feel better. Like we talked about, most of the work is done on your own. Like if you can do things on your own and do this exercise, you can have a big impact on this most times. Sometimes you need help. Like, saw me stretching that one patient when I was standing. There's other stretches we do here too. Most cases I can resolve within 6 to 8 treatments, and you can achieve your goals 2 times a week coming here. But not everyone. Some people are even quicker. Or some people say, give me an exercise. Let me see how I do. I'll just go home and I'll try it. If I need you, I'll call you up. I said, great, try this exercise. And they'll send me an email. I'm having some trouble. I'll say, come on in. I think I'm doing well. I think I'm starting to respond. So we'll keep on doing what you're doing. So that's basically it. So before we get into this, I'm just going to show you how we have people move and what we do as far as an evaluation. We're going to show Don's going to come here. Kathy's husband was nice enough to come down today. And we're just going to have him go through a few movements and how we evaluate. Okay? So let's have you stand right here, Don. So first, what I'll have you do, we didn't talk about the history. I'll ask Don, I'll say, what Don doesn't have any lower back pain, thank goodness. But we'll ask him his history. We'll say, what makes it worse? What makes it better? And we'll go through a checklist of different things. What's worse, what's better, when did it start? What was going on at that time? What occurred? Did you all of a sudden do a new activity or you're sitting longer? We'll ask him if he's happened in the past. We'll go through a whole thing. We'll ask him to note on this diagram where his pain is located, the type of pain that's going on. But first, after we go through all this, we ask him about medication, taking medication. Does it hurt when you cough? We go through this whole checklist, ask about the sleep disturbance. Remember I was saying about night pain, unexplained weight loss we talked about. Then in the second part, we're just going to check how he moves. We're going to see how, I was watching him when he was sitting down here, and he seemed to have pretty good posture. He's pretty upright, so that's good, and we'll check posture. But we're first going to check his range of motion. Okay, so the first thing we're going to do is we're going to say, just stand up nice and comfortably, and we're going to have you go forward as far as you can, and I'll demonstrate. Go as far as you can. We want to make sure you go as far as we can. So let's try that, Don. That's good, and stand back up. It's pretty good range of motion there. And also, how are you feeling? Which I forgot to say. I normally ask him, well, are you feeling any pain right now? We know Don doesn't have pain, but if Don had pain, we'll say, well, where's your pain? And he may say, oh, it's in the lower back or the leg. Okay, good. When you go forward, what happens? And that's the question. Does it worse, better? Does it change it? No, it feels fine. Okay, now what we're going to do is we're going to place our hands on our hips, and we're going to lean backwards as far as we can. Let's see how far Don's moving. Not bad. Well, I'll tell people, try one more time, Don, but let's try and keep our knees straight. So let the hips go forward, lean back as far as we can. Good. He's a little tight. He might benefit from working on a little bit of that arching. Maybe he's starting to develop something, but the first thing he has is he's lost a little bit of motion. So he may actually benefit from doing this exercise that we showed a little bit more before he even develops pain. Like I would probably tell him, hey, Don, try this. I think he might be starting something. So if he works on this motion, he may prevent an episode. So that was kind of interesting. So the next one we're going to do is we're going to face here. And we're going to do a side, make sure I don't knock my mic off. We're going to do a side glide assessment. We're going to have you shift this way and this way. So I'm going to, and this is a funny motion, so I normally guide people. So I'm going to take down your trunk's going to go this way, your hip's going to go this way, and then we're going to do the same thing the other way. Okay, one more time. And the whole time I'm looking like he's a little tight that way. Let's check this one more time. A little looser that way. Let's check this way. It's a little tight that way. So if you had pain, I kind of think that might be a movement we might want to do. So then after that, we're going to pick what do we think might help him based on best evidence. Well, he looks like he's a little tight in arching. So why don't we go ahead and have him do a series of movements. So our whole goal is to have you do a series of movements and see what the reaction is. So let's pretend Don has pain right down the side of his right thigh right now. So the first thing we're going to do is, since it looks like he's a little tight this way, he's got great range of motion this way actually. I'm impressed. Hands here, we're going to have him lean backwards, pressure on, pressure off. So let's do that a series of 10 times. Try and keep your knees straight as you do it. And what you notice when you get really excited, you notice that they actually start increasing the range. They actually start moving further in the same session. Like sometimes it's 10 times, sometimes it's 30 times. But as he's doing it, what I'm talking to him about is I'll say, hey, Don, how's that leg pain? Is that pain moving down your leg? Bad sign. Is the pain moving up your leg? Good sign. So Don doesn't have pain, so I'm going to tell him what he's going to tell me. Right now I'm going to tell him, wow, I think the pain is moving up a little bit. Great. So there's nothing below this point, Don. No, Tom, it feels pretty good. Feels good. All right. You know, Don isn't increasing his range right now, but I'll be taking someone, I'll talk him through a series, sometimes 30, 40 movements, and slowly the pain will start moving up. In really great cases, when I feel like I'm a rock star, it actually goes away in the first session. It doesn't always. Sometimes it's, and oftentimes it's someone that has to do it repeatedly. All right, let's pretend like Don now has just pain here, he has no pain here. That is often, you know, a sign that that's the right exercise for him. Okay, even if it doesn't take it away, just the fact that it moves up is a great sign. The research shows a great sign if you can move it in the first session. They feel a little bit better. Okay, then we're going to recheck the other motion. So let's go forward again. Let's see what that motion looks like. Go as far as you can. Yeah. So he didn't lose any motion there. That's pretty good. Feels all right. We can check the side glides, but basically it's repeated motion. We're moving the patient over and over to see. Now, if Don said in his history, you know, I like to sit more, I may actually start out with having him do repeatedly flexing forward to see if that helped him. But it's a guess by the therapist, that the best guess based on the movement and also what Don told me about. So that's part of the assessment. We'll also check some strength in your legs. We'll check your reflexes. So I'll show you how we check strength, and we'll get a baseline, especially if someone says they feel a little weak. All right, so let's have you sit on the table here. All right. All right, let's have you take your shoes off too. Don has been so good to take his Saturday with me to hang out. Talk about low back pain and sciatica, and if you don't have it, it's not that exciting. All right, so you're going to bring your leg up as high as you can. Hold right there, resist me. Good, bring your leg down. Bring your leg out, hold right there, resist me. Good, little cracking in there. Bend your knee back. Hold right there, resist me. Okay, bring your foot up, resist me. Toes up, resist me. Doing great, Don. Turn your foot in, resist me. Turn your foot out, resist me. Good, curl your toes. Curl them like that. There you go, resist me. Good. He doesn't have back pain, but occasionally you'll see weakness in a certain area, and we're going to note that. So if he starts doing some movements, the next time he comes in and he goes, you know, I'm feeling better, but I feel a little weaker in the legs, we'll recheck this to make sure he's all right. We'll also check his reflexes. I don't have my reflex hammer, but we'll check this reflex here. Was the patella tendon, the Achilles reflex, and if that changes too. And also just to know where he's starting. As part of the safety in the system, we'll check sensation. We'll take a little part of our reflex hammer and check along the legs and say, well, I don't feel, doesn't feel right. It's either numbness or not the right sensation, and we'll check and compare to the other side. Okay? So that's part of the assessment. It's a very brief introduction here, but that's some of the things we'll check just to make sure everything's good. For Don, I think what I'd give him, since he's a little tight, even if he came in, some people come in and they say, wow, I don't have any pain today. Go figure. I made an appointment with you. I don't have any pain. But based on his movements, he looks a little tight. So I'll tell him, why don't you try this exercise? Based upon your movements and your history, I think you want to arch this, and you want to do it 10 times every 2 to 3 hours. And after 2 or 3 days, we'll see where you're at. Sometimes I'll have people come in the next day if I really are careful, I'm concerned that they may need a little feedback and a reassessment. But that's basically it, and that's his motion. We will repeatedly check other motions. We also check people doing motions on the table and non-weight bearing, like the photos earlier. We'll do a knees to chest or that prone press up, a little prop up on the table. So those are some of the things we can have that will kind of like, you know, that's part of our assessment. So let's go through a few quick tips before we wrap up. If there's any comments, just send it there, or share this video if you have someone that thinks they'd benefit or don't quite understand what we do here. That's probably the biggest thing. So let's go over. We're going to go over the sleeping rolls. Okay. I'm going to show Don a neck. This is actually a neck roll thing, cervical roll, and this one right here. I'll have people do this for neck issues. But I figure you get a little extra value. If some neck pain, you happen to be on this workshop, you take a roll like this, or even take like a bath towel, put some rubber bands around or duct tape, or you can buy one of these here or online, You place it on the very bottom here of the pillow here. So what have you done? I'm going to have Don rest and show him. He's going to actually rest up here. He's going to put his head up this way. So let's lie down, Don. And this roll essentially is going to be right below his hairline here and right to his shoulders, okay? And that's going to keep the normal curve of his back, of his neck. So this is, I know we're talking about lower back pain and sciatica, but I just wanted to give you a little feedback for neck issues if you happen to have it. Sometimes you have both at the same time. We're putting that roll right here where we have a little bit of a natural curve, and we want everything just to rest evenly. That's kind of the idea. Also, you can also do it in side lying. So as you lie in side lying, there's a little indent here, and I'll have people place the roll in side lying. So Don, let's go ahead and, I'm sorry I called you Ron. Don, let's have you lie on your side and face me here. And this is on one of the videos, and we try and put it just a little bit lower, like a little bit closer, like that, and essentially in the very edge of his neck, and it typically works better if you're a back sleeper, I'll be honest. All right, so let's have you sit up. The last thing here is called this is a night roll. This essentially goes around your body like so, and you tie it. Actually, Don, you can stand over there. I'll show him this one. So you're essentially going to place this roll around your waist, like this, and just tie it. Okay, and this is supposed to create that normal arch for your lower back. It's trying to support that arch at night. Not everyone benefits from this roll, but this is one that you can use. So I'll have people lie actually, they can lie on their back like this, or they can lie in side lying. Just like with so if you, this will keep that curvature on your side, especially women that have a wider pelvis. They can lie like so, and they should feel better with this. This isn't something that you should use and say, wow, it hurts, but I think it'll be better for me overall. It should feel good that night. But like anything, different roll thicknesses are this is one standard roll. I think this is a small one, small to medium. Anyway, there's two types, and you can check, you call me up if you want as far as the website. But this is great for people that have pain, especially at night or waking up in the first 1 or 2 hours in the morning. This is something that could help you out. And we did a whole video on this roll too, and it gives you some good information. So this is a roll, and this is also the cervical roll for lying down. You can make it up. It's nothing special, but the towel, you just got to play around with the thickness. Right? Okay, lastly, so these are all tips, either preventative tips or if you have back pain. The last thing too, Don, can you get that chair over there? We're going to show you how to do use a lumbar roll. Now, great. Okay, so what we're going to do is, the way to use a lumbar roll is we're trying to create this curvature here in the lower back. Okay, we're trying to keep that nice little indent there. Okay, so most people when they sit have problems. Most people that have lower back pain have problems with sitting. So this is kind of an old nasty roll right now, but anyway, this will do for our purposes. So the best way to use a lumbar roll is to get down into the chair like so. In fact, let's have Don do this. Don, can you sit right there? And I'll tell patients, make sure your buttock is all the way back in the chair here, as far as you can. And then what I want you to do is I want you to lean forward from that position, and you're going to put the roll just above the belt line, snug in here. Some of them actually have straps around the chair. And then you're going to lean back into the roll. And all we're trying to do is create that little curvature. A lot of people have it in the newer cars. They have lumbar supports. The biggest thing people don't do is their buttock moves forward and essentially doesn't create that curvature, and it just doesn't work. So it's really important to make sure you get as far back into your chair and really use that lumbar roll right above the waistline. Okay, but most people use these incorrect. In fact, I'll have Don to slide forward. So slide forward a little bit, your whole body, like this. Now lean back into this. So with this, you can see he's just keeping that flattened back, and the flattened back is typically not great. It's out of the normal anatomy there. So those are some tips as far as prevention, or in the car you can use a roll. Sometimes the lumbar supports don't fit your back, so you got to see what works, but it should feel better. It shouldn't feel worse. Sometimes for someone that's very petite and small, this roll will actually be too much for them, so you need a smaller roll. So you got to play around with that and see what works for your back. So anyway, so that's our talk for today. You can sit up, Don. Thanks very much, Don, for helping me out. So we went over a bunch of things today. This is just a tip. We basically go through a lot of these things. In your evaluation, we do a lot of education. we take you through more an extensive evaluation than we did. And we didn't talk about the history as much as far as talking to the patient about things that make it worse, make it better, when it occurred, how it started. But you kind of get an overview of how we look at that. We also have a similar evaluation for the neck, and we'll talk about that in another workshop. But hopefully you have a better sense of where to start and when you really need to seek care. So best of luck. If you have private insurance, you can come in here. You don't actually need a prescription from your physician. Unfortunately, with Medicare, you need one from your doctor, but you can, if you want to come in, you say, listen, I'm having lower back pain, they write a prescription, you can come in. We're a Medicare provider. So it's just some things to consider. And I think that's about it. Now let's go for the next slide. Great, that's the kids. We're down in North Carolina many years ago, surfing poorly down in North Carolina. But anyway, thanks for joining us. I hope you got some information, you learned a little something, and hopefully you can make a better decision regarding your health. And ultimately, that's what we hope we empower people, is where to go for help, and just so you can keep moving a little bit better, a little less pain, improve, and kind of maintain your mobility, and not take something that you enjoy, your passion out of life. And that's the most important thing. So anyway, have a great one, and thanks for joining us. And share this to anyone that you think might help, and like us if you think you benefit from this video. Okay, have a great day. Have a wonderful weekend.